My name is Dr. Pankti Gajera, lecturer in physiotherapy in cardiopulmonary conditions, working at UN Mehta Institute of Cardiology and Research Center. Today we are talking about assisted cough techniques. So let us see. The contents of this topic are introduction, cough pump, stages of cough, active assisted cough techniques, breath stacking and manual chest compression, assisted cough techniques which involve manually assisted techniques and self-assisted techniques, cough assist machine and references. So let us see about what is cough. Is one of the most frequently reported symptom in patients with pulmonary impairments. The mucociliary escalator functions as the primary means to clear secretion and inhaled particulate matter. If the patient does not have the mechanical ability to have an effective cough, assistive cough techniques or mechanical methods, for example, patients with neuromuscular weakness or paralysis as in spinal cord injury. So these are the indications for assisted cough technique. For these patients, coughing technique will increase a deep inspiratory effort paired with trunk extension, a momentary hold, and then a series of expiratory coughs on a single breath while the patient moves into trunk flexion. That is an effective strong cough, which the normal individual can do, but the neuromuscular weakness patients cannot do properly. So now what is cough pump? The cough pump is an intricate device. Mucus must be transported upward against the gravitational force and propelled cephalate by the expiratory gas flow. The work by cilia. Generally, cough is the most effective means because it has a large inspiration and high expiratory flow rates. Cough will clear to approximately the 6th or 7th generation of airway segments, which are the medium diameter of airways. If the patient does not have the mechanical ability to have an effective cough, as in spinal cord injury patients, assistive cough technique will have to be employed. So there are stages of cough. There are 4 stages are involved in producing an effective cough. So minimal threshold of forced expiratory volume in 1 second, that is FEV1, of at least 60% of patient's actual vital capacity is a good indicator of adequate muscle strength necessary for effective expulsion. If individual have FEV1 of 60%, so we can say that he or she has an effective cough. A minimal peak flow rate, that is PCFR, of 160 liter per minute to effectively clear secretion and to predict successful decannulation for patients with neuromuscular condition, patients which are on tracheostomy for longer period of time. During a cough, alveolar, pleural or subglottal pressures may rise as much as 200 cm of H2O. So when mucus plugs are transported from periphery to center, patient feels irritated and cough reflex is present. So in stages of cough, first stage is adequate inspiration. Patient is inhaling proper volume of air in lungs. After proper inspiration, the second stage of glottal closure, that is glottis that is closed. After glottis closed, there is pressure rise in intrathoracic and intra-abdominal pressure, so which can help in proper expulsion or proper forceful expulsion after glottis open and there is mucus plugs out of the lungs. So let's see about active assisted cough techniques. If after instruction and modification in patient's cough, the patient still cannot produce an effective cough, then one of the following assistive cough technique may be appropriate. Keep the coughing process as active as possible for each patient, whether that is accomplished by adding a few verbal cues to improve overall timing or posture with the patient independently performs the cough, or whether it is accomplished by adding eye gaze for a very weak patient who cannot move the upper extremities and breathes with the assistance of ventilator. So we can say that as much as possible we have to make the patient to active cough. That is for betterment of patient. Encourage the patient to be responsible for his or her own care by teaching the concepts involving in producing an effective cough, that is maximal inspiration, forceful expiration, huffing or coughing, etc. So there is one technique, that is breath stacking and manual chest compression. Breath stacking is a technique that is achieved by patient independently performing inspiration to maximal inspiratory capacity when holding the breath and taking in 2 or 3 more breaths on top of the initial breath to increase vital capacity. As we can talk about the floors. So if one can inspire somewhat volume, then after that one more inspiration over that, one more inspiration over there. So in this manner 2 to 3 inspirations on top, and that increases vital capacity, and that is followed by cough. For a patient with neuromuscular weakness, a therapist or family member can do chest compression and assess the cough during exhalation. During cough, the therapist or the relatives of patients can do chest compression while coughing. In a study of patient with Duchenne muscular dystrophy, variations of breath stacking with a manual self-inflating bag were tested. So one group simply used the self-inflating bag for breath stacking, whereas other group used a combined technique of breath stacking with the bag plus manual compression of exhalation. So the group which used a combination technique proved that the most effective as measured by peak cough flow. So now the techniques, assisted cough techniques. There are 2 assisted cough techniques. One is manual and second is self assisted. So in manual we can learn costophrenic assist, Helmich type or abdominal thrust assist. Third one is anterior chest compression. Fourth one is counter rotation. And in self assisted techniques there are 5 techniques. One is prone on elbow, head flexion, self assisted. Second one is long sitting, self assisted cough. Third one is short sitting, self assisted cough. Fourth one is hands, knee rocking, self assisted cough. And fifth one is standing self assisted cough. So first one is manually assisted coughing. In that, first one is costophrenic assist. Most appropriate position for the patient, most often sitting or side lying. Therapist places his or her hands on costophrenic angles of the rib cage shown in the picture like a V shape. Both the thumbs are at costophrenic angle. So procedure is, at the end of exhalation, while patient doing exhalation, after exhalation the therapist applies quick manual stretch down and in toward patient's navel to facilitate stronger diaphragmatic and intercostal muscle contraction during the succeeding inhalation. The patient may assist the maneuver by actively using his or her upper extremities, head and neck, trunk, or all of the above to maximize the inspiratory phase. The patient is then asked to hold it. Just a moment before asking the patient to actively cough, the therapist applies strong pressure with his or her hands, again down and in towards the navel. The therapist can also apply a series of repeated contractions throughout inspiration to facilitate maximal inhalation. therapist is assisting both the building up of intrathoracic pressure and force of expiration. The uses of this technique are in patients with weak or paralyzed intercostal or abdominal muscles. The therapist must remember to evaluate the effect of gravity and posture in each position for the appropriateness of this technique, and technique is very easy to learn and teach. Now second one is Helmich type or abdominal thrust assist. This method requires the therapist to place the heel of his or her hand at above the level of patient's navel, taking care of to avoid direct placement over the lower ribs. So you can see in the picture how the heel placement over the costophrenic angle, not over the lower ribs but at the navel of the patient. In procedure, patient is instructed to take in deep breath and hold it. The therapist can then facilitate inspiration. As the patient is instructed to cough, therapist quickly pushes up and in under the diaphragm with the heel of his or her hand as in Helmich maneuver. So thrust up and in during cough. The patient is instructed to assist with appropriate trunk movement as much as possible. While coughing, patient can do trunk flexion that assist in cough. Technically, this procedure is very effective at forcefully expelling the air as in the cough, but it can be extremely uncomfortable for the patient for several reasons. Its concentrated area of contact, its abrupt nature, because of the thrust, which may elicit an undesired high neuromuscular tone response, or worse when combined with the sensory input supplied by the therapist manual contacts. The force which may cause gastrointestinal dysfunction such as GER. Because of its limited usefulness, it should be used only when patient does not respond to other techniques and the need to produce an effective cough. The uses of this technique in a patient with hemiplegic deficit or has a unilateral lung or thorax disease or trauma. Third one is anterior chest compression assist. It compresses both the upper and lower anterior chest during the coughing maneuver. This is the first single technique thus far to address the compression needs to upper and lower chest in one maneuver. The therapist puts one arm across the patient's pectoralis region, and that is upper chest, to compress the upper chest, and other arm is placed parallel to the lower chest, avoiding xiphoid process or on the abdomen. After patient is instructed to take in deep breath and hold it, therapist can facilitate inspiration. After that, therapist applies a quick force with both the arms to stimulate the force necessary during the expulsion phase. There are two direction of forces with the two different hands. First one at the upper chest down and back, and with the lower chest up and back. So when we are doing together, it forms V, letter V shape. So both the forces forms the V letter. The anterior chest compression technique is more effective than the costophrenic assist for patients with very weak chest wall muscles who cannot effectively cough properly. Because of the added compression of the anterior chest wall, most effective in side lying or 3/4 supine position. This technique is not appropriate for the patient with a cavus condition of the upper anterior chest because it promotes further collapsing of the anterior chest wall. Fourth one is counter rotation assist. Patient position in side lying position with the knees bent and arms resting comfortably out in front of the head and shoulders. Higher the upper extremity can be placed within comfort zone, the better the result. The patient's position is also, the therapist position is also important because it directs the force that is applied to the patient's chest For example, if patient is lying on left side, therapist places his or her hand on the patient's shoulder and the right hand on the patient's hip and simply follows patient's respiratory cycle. This allows therapists to assist patient's subjective respiratory rate and rhythm and the patient's overall neuromuscular tone. So, like this, in first picture, hand placement during expulsion phase, that is during coughing phase, manually compresses the rib cage on all three phases of ventilation at the end of exhalation by gently pulling shoulder back and down while simultaneously pushing the hip up and forward. These movements promotes more complete exhalation. So, the therapist turns the patient up and therapist turns the shoulder back and down and hip up and forward. In the second picture, that is the hand placement during inspiration phase, slowly stretches the chest to maximize inspiration tidal volumes. The therapist's left hand pushes the scapula up and away from the spine and the right hand pulls the pelvis back and down to maximize all three planes of ventilation, that is anterior, posterior, transverse, resulting in greater inspiration. The therapist gently assists patient in inhalation and exhalation to promote better overall ventilation. This sequence is generally repeated to 3 to 5 cycles or until the patient appears to have achieved good ventilation to all lung segments. At this point, patient is ready to begin their coughing phase. The patient is asked to take in deep breath as possible, with the therapist assisting patient in chest expansion. Next, therapist instruct patient to hold it and end of the maximal inspiration. Patient is then commanded to cough out as hard as possible while therapist quickly and forcefully compresses the chest with his or her hands in their flexion phase position. Using PNF technique called rhythmic initiation, patient is gently log rolled in a small range of motion in the sideline position. The rolling is gradually increased, achieving more range of motion from sideline towards prone. When done properly, the counter rotation assist is the only technique to rapidly close off the chest cavity in all three planes of ventilation in all areas of the chest. Unless the patient voluntarily closes his or her glottis, that is impossible to prevent the air from being forcefully expelled. So, the effects of counter rotation technique for patients with low levels of cognitive functioning who cannot understand the technique properly. The rotation, because it is the assisted by therapist, so the rotation component is a natural inhibitor of high tone. General rotation before passive coughing in a patient who is comatose can reduce high tone and frequently reduces high respiratory rate. Second one is counter rotation is an excellent mobilizer for the tight chest, which can facilitate spontaneous deeper breaths. Tidal volumes can therefore be increased for many patients by mobilizing the chest walls. And finally, rotation can be vestibular stimulator and may assist in arousing the patient cognitively, allowing him or her to take more active role in procedure. Next one is self-assisted techniques. These coughing techniques are intended to be used as self-assisted procedures. So, they are usually taught later in patient's rehabilitation process when the patients are ready to assist him or herself and they didn't need any therapist assistance. Patient need to learn to cough in whatever position they are in for therapy or rest. Suggestions for variation are included. So, first one is prone on elbows, head flexion and self-assisted cough. The head flexion assist requires good use of head and neck musculature seen in patients who have sustained a spinal level injury below C4. For example, spinal cord injuries, spina bifida. It can be used either as a self-assisted or a therapist-assisted procedure using the principle of trunk extension to facilitate inspiration and trunk flexion to facilitate expiration. This is the major principle while cuffing. In technique, patient position is prone on elbows. Therapist instruct the patient to bring head and neck up and back as far as possible, inhaling maximally, that is extension phase. The patient is then instructed to cough out as hard as possible while throwing head forward and down, that is flexion phase. This pattern can initially be assisted by therapist to establish the desired movement pattern and gradually progressed to a resisted pattern to promote increased accessory muscle participation and to strengthen muscles. Prone on elbow can be an effective posture for promoting spontaneous use of accessory muscles during more difficult activity. However, without the full recruitment of diaphragm, the resultant cough will be weaker than it would be in other postures. For the population of patients who can assume a prone on elbow posture independently, that is some patients with tetraplegia, this technique may be used functionally. In this position, they can assist their own coughs when the need arises rather than wait for someone to assist them in a position change. So, this technique can patient independent. Second one is long sitting self assisted technique. In this technique there are two variations. First variation is for tetraplegic patients, in which patients the whole four limbs are paralyzed or weak. In tetraplegic patient, position on a mat in a long sitting posture, legs straight out in front and with upper extremity support. Therapist instruction: extend your body backward while inhaling maximally. So, this is first picture is for maximizing inspiration phase. The therapist then tells the patient to cough as the patient moves his or her upper body forward into completely flexed posture using shoulder internal rotation if possible. Once again, extension aspect of procedure is used to maximize inhalation, whereas flexion aspect is used to maximize expiration. So, in first picture that is extension phase, that is maximizing inspiration phase, while hands are behind the body. That is for assistance. And second picture is flexion phase, that is maximizing expiration or cuffing phase. Second variation is for paraplegic patients who have only lower limb weakness or paralysis. Some principles are those described for same principle as those described for tetraplegic patient. Patient position is his or her upper extremities in a butterfly position or uses elbow retraction depending on level of injury. So, this is the position for patient in butterfly position. During the flexion phase, patient throws themselves into their legs, thereby compressing both the upper and lower chest. This can be taught very successfully to patients with paraplegia provided they have adequate trunk balance control. If the patient lacks hip flexion or he is worried about bony contact or skin injury, place a pillow or two as needed on the legs. This will limit the hip flexion and minimize trauma from quick thrust onto the legs. So, in first picture, this is the extension phase, maximizing inspiration phase, and while flexing forward, maximizing expiration, that is cuffing phase. However, paraplegic patients have active spinal extension musculature and can achieve greater trunk extension and flexion safely, thus achieving greater chest expansion before cuff and greater chest compression on a superior inferior plane during the cuff. So, third technique is short sitting self assisted cuff. In this, patient position is sitting on wheelchair or over the edge of the bed. Place one hand over the other at the wrist and place them in his or her lap. So, this is the patient's position, sitting on a chair, wheelchair or edge of the bed, and hand placement on the lap. The patient is then asked to extend trunk backward while inhaling maximally, followed by strong voluntary cuff. During the cuff, patient pulls his or her hands up and under the diaphragm, resembling the motion of Heimlich maneuver. The hands mimic the abdominal muscles, which would ordinarily contract to push the intestinal contents up and under the diaphragm to aid its recoil ability. Which we you see in Heimlich maneuver. So, the same procedure, extension phase and the flexion phase, in which patient slightly thrusts the abdomen and cuff. The short sitting technique uses the diaphragm more substantially than the long sitting procedure and is therefore generally more effective as an assistive cuff. It is an effective self-assisted method for patients who have weak diaphragm or abdominal musculature, patients with spinal cord injury or spina bifida at C5 or below level. Patients with tetraplegia usually require trunk support and or seat belt from their wheelchairs to perform it independently and safely. Paraplegic patients can perform it from an unsupported short sitting position. So, variations are welcomed. Fourth technique is hands knee rocking self assisted cuff. In this, patient assumes an all four position on hands and knees. So, this is the position for patient. He or she is then instructed to rock forward, looking up and breathing in while moving to a fully extended posture. Then patient is told to cough out as he or she quickly rocks backward to the heels with a flexed head and neck. The rocking can be done with or without a therapist assistance. Once again, note the importance of flexion and extension components of cuff. So, while in all four position, patient rock forward for inspiratory phase, while rocking backward, that is expiratory phase, and patient can cough. This is performed most commonly as a multipurpose activity to increase the patient's balance, strength, coordination and functional use of breathing patterns, including quiet breathing and coughing simultaneously. For patients with generalized or spotty weakness throughout, for example, some patients with spinal cord injury, head trauma, Parkinson disease, multiple sclerosis, cerebral palsy or spina bifida, this method is perfect for incorporating many functional goals into a single activity. It can help prepare them for more challenging respiratory activities. Last and final one is standing self-assisted cuff. In standing, the standing uses same concept as previously discussed and can be readily used for self-assisted cuff provided the patient has adequate standing balance and upper extremity support. So, in standing, patient slightly extended maximal inspiration, and while flexion, patient can cough. And in standing position, the variations of upper extremity, lower extremity and trunk can be used. Any technique previously described can be modified for this posture. If patients are unable to be independent and assist in coughing to remove secretions, other options will be necessary. that is suctioning. It is not always tolerated well by patients. Mouth suction or oral suction is usually appreciated and easy to use, but patients with tracheostomies and endotracheal tube usually require more invasive and more uncomfortable. Cough assist machine, previously known as coughletter or mechanical insufflator exsufflator, is a non-invasive machine used for airway clearance. A new device to be superior in comfort and in effectiveness in removing secretions. A positive pressure phase, that is insufflation, is followed by a negative pressure phase, that is exsufflation, stimulating cough. This device can be used as a face mask or attached to a universal adapter for a tracheostomy tube. Mechanism of action of the cough assist machine is to improve peak cough flow. The cough assist machine has been used primarily in adults, but it is being used more and more in children. So, this is the reference, and thank you.